The story of Stafford is, to a very significant extent, a story about a failure of leadership. And I'm going to start, if I may, with this quote from the former chair of the Consultants Committee, in evidence he gave not to this inquiry, but to my first inquiry. And what he's a physician. What he said was this: surprising though it may seem, surgeons are calmer than physicians. I drew it, that was a ward configuration that was disastrous, to their attention, and they said, yes, we agree, it's not satisfactory. And because they had no other beds, they had to use that ward. So they said, we've got to go on doing our job because we have patients who need operations. We will have to mend and make do, which is the Stafford way. And it is true, and it is commonly said, that the clinicians at Stafford did not speak up when they were discontented with the way things were going. They made mend and made do. And I think it may be slightly unfair of this consultant to have said it's the Stafford way. The question which we may have to ask is whether it's the NHS way, or has become so, in an organisation where clinical leadership does not either exist or doesn't mesh happily with management leadership. Moving on to something which is meant to govern leaders in the NHS, at least the NHS managers, and I have in the course of the inquiry heard a certain amount of debate in evidence as to precisely who this code of conduct is meant to apply to, but it might be thought that its principles should apply whether it's in someone's contract or whether it's not. But the principles here are clear, and they came out in 2002 following the Bristol inquiry, and they include making the care and safety of patients my first concern, and to act to protect them from risk, to respect the public, patients, relatives, carers, NHS staff and partners and other agencies, to be honest and act with integrity, to accept responsibility for my own work and the proper, I emphasise that word, performance of the people I manage, to show my commitment to working as a team member by working with all my colleagues in the NHS and the wider community, and to take responsibility for my learning and development. And this means, in particular, the use of resources in an effective and efficient and timely manner, having proper regard to the best interests of the public and patients. One of those factors under that is to be guided by the interests of patients while ensuring a safe working environment, and to act to protect patients from risk by putting into practice appropriate support and disciplinary procedures. One wonders, in parenthesis, whether perhaps that's the first and most satisfactory way of protecting patients from risk, but at least it might be thought to be a start. Can I then turn, please, to the people that this inquiry is all about? And I'd ask you to bear in mind in everything that you have to say. We are here because a large number of patients and those who cared for them were let down over a sustained period by the service they received. You see on the screen some members of Cure the NHS, who were all people whose lives have been profoundly affected by what happened. They want not only to know why their relatives were allowed to suffer as they did, they want the system to change to reflect that experience. Some of them have sat through virtually every day of the 133 days of evidence we have heard. And I'm now going to mention one case, which those of you who were here last time will recall me doing so again, but I don't apologise for it, because it's a case which managers and leaders of the NHS need to ensure that does not happen. A lady called Mrs. Asprey died on the 11th of April 2007. She was 66 years old and had been admitted to hospital on the 1st of April via accident and emergency with a fracture following a fall. She was a known insulin-dependent diabetic, and those accompanying her to hospital told all that they met of that fact. A doctor registered the information, wrote up a prescription for insulin, and made a referral of the patient to the dietitians to make sure that her diet was appropriately controlled. The administration of insulin being dependent upon her blood sugar level, which therefore had to be tested. It doesn't appear she was given insulin when she needed it. Nursing handovers of the need for insulin and indeed its claimed administration were not recorded if they hadn't at all. There was nursing evidence available to her eventual inquest that on one occasion a senior nurse came on duty and found her and indeed another patient covered in their own faeces. Not only was she not given insulin when she needed, she was found eventually in a collapsed state from which she failed to recover. The pathologist's opinion was that she had died through diabetic ketoacidosis following insulin deficiency. The family received a letter of condolence quite promptly, dated the 18th of April. It said nothing about any concerns about the level of treatment this poor lady had received, but at some point after that, the Trust undertook an investigation via its in-house solicitor. And in a comprehensive report, he made, amongst other findings, these findings. I won't read them out, but because they're easy to see on the screen. You might think that they clearly showed, in this one case, a serious situation going far beyond the incompetence or misconduct of one person, but matters of concern for the safety of a wide range of patients. This report was not shared with the family of the patient until May 2008, over a year after the lady's death. At some point, the matter was reported as a serious untoward incident to the Strategic Health Authority, but there's no evidence that either the SUI report or this investigation report were either read or registered. The Health and Safety Executive conducted an investigation which identified multiple systemic failings. To date, they have made no decision whether to prosecute or not, but it's not in general their policy to do so in healthcare cases. On the other hand, the Care Quality Commission states it doesn't prosecute individual cases. The matter was referred to the coroner eventually, but an inquest didn't take place until September of last year. This is an extract from the jury's findings, where they identified serious shortcomings in the systems and in the implementation, monitoring and management of the systems in place. The police investigated, but the CPS has decided there are no grounds for prosecution. Now, almost simultaneously with the death of Mrs. Asprey, Dr. Foster Intelligence published its ratings for the HSMR, which placed this trust as the 5th worst in terms of unexpected mortality in the country. And if you look down the white column, you'll see that the unexpected rate of mortality had been significantly above that expected for really some time before that publication. The Trust's reaction, however, was to attribute the problems that might have been exhibited, and everyone knows HSMR is not a perfect tool, to coding issues. And they really looked no or very little further than that. And they were able, the executive was able to report to the board in June of 2007 that it didn't believe that it had any significant clinical problems which can be attributed to the high mortality rates. Alongside that more generic figure, the Trust was receiving mortality alerts in July, August, September, October, and November of 2007, all relating to specific diagnoses. After a focus on coding inadequacy, the board felt able to reassure Monitor in its Foundation Trust application that it had, and I quote, no problem with mortality, based in part on 2 months' figures or so, between a few more than that, perhaps May to August, when, according to them, the mortality rate had gone down to 101. It also told the Monitor that the CHKS had undertaken a report telling it that it had no no problem with mortality. CHKS has denied to our inquiry that they ever undertook any such report, and certainly no copy of it has been capable of being produced to the inquiry. Monitor therefore was able to grant Foundation Trust status to the Trust in January of 2008 in ignorance of the true facts, and also in ignorance of the fact that the Healthcare Commission was considering launching a formal investigation, although the Trust knew of that possibility before that date. It would be nearly a year before after Mrs. Asprey's death, before the Healthcare Commission launched its investigation, and a year after that before its report was published. When the report was published, the chair resigned and the chief executive officer stepped aside and eventually left under a compromise agreement, motivated in part by Monitor's wishes and in part by the desire to move on. This is an extract from the evidence given by the interim chair about the moving on of Mr. Yates. I've explained the reasons why we did what we did. It wasn't a satisfactory outcome. There were clearly responsibilities that needed to be answered, but overwhelmingly we needed to move the agenda forward, so the action we took was taken. Asked to what extent was this because you were afraid of getting bogged down in a long and expensive legal process, that was a factor, Chairman. So the Chief Executive, the public say, has retired with his pension intact. He was unhappily and sadly significantly and seriously ill to the extent that he was unable to give evidence to answer any of these points to my inquiry orally, although he did make a long and comprehensive written statement. The situation, of course, for him would have been very different had he had the misfortune to be on the medical register. Dr. Roylance, who I should say I represented before the General Medical Council, not very successfully, regrettably, was erased from the register because of the events at Bristol, which led to the Kennedy inquiry. And his erasure was upheld by the Privy Council on the basis that as Chief Executive, the duty arose out of his holding of his appointment. As a registered medical practitioner, he had the general obligation to care for the sick. That duty didn't disappear when he took on the appointment, but continued to coexist with it. There was a sufficiently close link with the profession of medicine in the case of the appellant as Chief Executive of a hospital in respect of patients at the hospital. And then at the bottom, the idea of a gulf between the medical practitioners and the administration, connected by some bridge over which the appellant had passed from us to them, must be totally unacceptable if the interest of the patient is to remain paramount. The enterprise must be one of cooperative endeavour. Dr. Roylance would happily for him had retired from work by the time of this decision. But if he had not been, he could not have found work as a doctor, and one would have thought that an erased doctor would have found it very difficult to get work again as a manager. Had he not been on the medical register, there would have been nothing to stop him at least applying for work in a similar post elsewhere. Of course, he might not have got it, but there would have been no accounting to the public. And if Mr. Yates had not been so ill that he'd be unlikely ever to work again, it might be thought the same would apply to him. Finally, and I've taken far too long, can I go back to Mrs. Asprey? Mr. Street was her partner who gave evidence to our inquiry, and he said this: "I'm not here for myself, I'm here for Jill and the rest of the dead. I'm not being sanctimonious. I could walk away at any time, but I'm not going to. When they took Jill away from me, they took away my contentment. I don't want anyone else to suffer that. Bereavement comes to us all, but it's how it comes to you that is important." And he, like the other people you saw in that photograph, would very much like your assistance, I think, in assuring that the NHS gets the leadership that it deserves and they deserve to ensure that these things don't happen again. Thank you.